All right, let's see. Do you guys see my screen?
Yeah, I see it.
I've got a few that I'll start out with here. Let's see who's on here yet. I guess we've got just a small core group right now. Um, this one's kind of interesting that I saw a couple weeks ago, and I'll just pull up the oldest case. Actually, I'll pull up this one from 2015. This is kind of surprising because I read the most recent case on this patient. As you can see, they have had a prior left upper lobe wedge resection, which was metastatic renal cell carcinoma. It's clear cell, and they have these other nodules, and there are a couple of them, like this one. I think this one right here is most notable. And again, I'm sure you guys handle these pretty similarly. It's kind of ovoid or flat, and it's right along a fissure. So these are the ones, even in patients with cancer, that I will usually say most likely benign, especially if they've been there for a while. And I can go back to 2010 and show you what it looked like here. That this was before he had the wedge resection, but this, I think that tiny little guy was, yeah, that guy was right there. And if I remember, there's a couple others that were similar to that, but tiny ones. But anyway, so that was 2010, and now 2016, this is the one I saw last month. And look at that. That lymph node, presumed little lymph node, is larger, and he's got more that are also in the same distribution, but all larger. So I think that this is all, that my guess is now that it's more metastatic renal cell carcinoma just to pre-existing intrapulmonary lymph nodes. And I'm curious what you guys think, because usually my practice would be, as long as they're stable, just say they're likely benign intrapulmonary lymph nodes. But you can see in this case, he's got these bigger hilar nodes as well, and this new one along the major fissure on the left. But I thought it was just interesting that after so many years, all of a sudden he has these growing nodules, which are, I guess, just presumably lymph nodes that are now involved with metastatic disease.
So, Travis, if you look at your one on the left, you'll notice it's rounded.
Oh, yeah, yeah. I agree with this one. Yeah, the one that's kind of abutting the fissure, but it's not in the fissure. That guy right there?
Yes.
Yeah,
I've seen this with melanoma where they metastasize to the intrapulmonary lymph nodes.
yeah,
But one thing that I find helpful is, we do coronals and sagittals on everybody, is you'll see the morphology will change because these lymph nodes get big when people go into failure or they aspirate, but they
yeah,
just in the mediastinum, they maintain their normal shape.
right. Yeah, because here's from 2013. This is the nodule that was resected, that was confirmed metastasis. And of course, that one was new from the priors. But then you have like this little guy right there, which is the one I showed you that's been there since 2010. This one that's been there since 2010, that all then grew up, blew up into bigger things. This thing was, again, actually, Jeff, that one kind of looks triangular there too. I think in that same location. But you're right, the morphology changes. So I still think it doesn't dissuade me from saying that these are most likely intrapulmonary lymph nodes, but that doesn't mean they can't have metastases in them. I think it's the point. And I'm just curious if everybody else agrees, and if that's your practice to usually say, as long as they're stable, they're likely benign.
Absolutely.
Yeah. And I think your point is good, Jeff, about looking at these in different planes too, and seeing that it's no longer a flat or disc-shaped thing, but they're much more round. So we'll see when we get more follow-up on this guy. This is a cute case that I saw a couple days ago, and I'll show you his CT from a couple months ago first. Actually, I'll show you this one from 2015. So this is a guy who has had head and neck cancer, and as you can see, he's got just tree and bud city here everywhere. He's got some larger airways that are full of stuff as well. And it's mostly, though, in the dependent portions of the lower lobes, as you see, and portions of the right middle lobe and lingula. Certainly looks like it could be a good distribution for aspiration bronchiolitis. And in fact, he has head and neck cancer, and so they suspected that. He came in this week for PEG tube placement, so percutaneous gastrostomy. And here's the radiograph that he had done. And so this was, I think it's pretty cool radiograph where you can see all of this aspirated high attenuation material. And so the backstory to this is all barium that was aspirated, and you can see he's got a some sort of enteric tube here. But the protocol here at UCSF when IR is going to place percutaneous gastrostomy tubes is they will often either inject or give the barium through a tube the day before, or in his case, he swallowed it because he didn't have a tube at the time, and they'll let it pass through the system for a day so that it outlines the transverse colon. So when they go in to make their puncture into the stomach, they know where the colon is. And so this was all just aspirated barium from that. So they aborted his G-tube procedure the next day because none of it was really in the colon. So I thought this was a cool, I think, just obviously now confirmed case of diffuse aspiration bronchiolitis. And he had head and neck cancer, so he's had a laryngectomy and had known risk factors. You can see this is a more recent CT, and he has a little bit more bronchiectasis in the lower lobes, but still a lot of plugged airways and small little tree and mud nodules elsewhere. So, but I think the chest radiograph is the most impressive. All right, and then I've got two infection cases here. This one I've tried to, Jeff is always the one that's good about getting path and getting pictures from bronchs and stuff, so I've got something to accompany that. This is a guy who had a liver transplant a few months ago, and then a month ago went to an outside hospital with some weight loss, general malaise, low-grade fevers, and reportedly had a pneumonia in his lingula. And this was about a month ago, so they treated him with antibiotics. Never really got better. And this is his radiograph from a couple days ago. And I'll just show you his CT from a few months ago, just really quick, to show you his lungs were completely normal at that time. And maybe you can tease out some tiny little nodules throughout his lungs. It's pretty cruddy portable. But here was his CT yesterday that I read, and you can see now that he has a nice miliary pattern, in addition to this more focal consolidation here. So, of course, all the different teams come by, and it was I was suspecting that this was going to be some sort of miliary infection like TB or fungal, and the ID team came by, and they had just seen the patient, knowing that we were suspecting a miliary disease, and it was the ID fellow that took this photo of his skin, and he has this little umbilicated lesion, had a couple more on his skin in different places, but they biopsied this last night, and it came back as cocci. So it's I think the pulmonary team, the general medicine team, had overlooked the skin findings, and they were going to do a bronch and biopsy, but the ID folks saw this, and so they biopsied it last night, and the smears are consistent with cocci. So he's from the Central Valley too, so this is most likely just a disseminated coccidioidomycosis infection, and I think probably started more as a lobar pneumonia here and is now disseminated. I suspect this is all part of the same thing, because I've seen a few cases where you still have more discrete consolidation even with the miliary pattern throughout the remainder of the lung. So I don't think the two are mutually exclusive. I don't know, Jeff, do you agree? Because I actually had I submitted an image to a paper with a miliary pattern, and there was an area of consolidation, and the editor actually asked me to submit a different image that didn't have the consolidation because they thought that confused the pattern. But I think it's...
No, I absolutely agree with you. I've seen a lot of cocci where you see it starts as consolidation, and in an immune intact patient, you'll be left with a cavity. But I've seen it start this way and then get bloodborne because it's inhaled, and then you get a miliary pattern. So I absolutely agree with your assessment.
Yeah, and he had...
Did he have lesions in his liver or spleen too, Travis?
Well, unfortunately, it's a non-contrast. It was really hard to tell. He has some ascites, and I don't know if this is all just a result of his prior liver transplant. He did have abdominal pain, so I wonder if he has some peritoneal or mesenteric involvement or something. But this was the only study we had which was non-contrast. So that's a very good question, though. But he also had headaches, so I wonder if he has some meningeal involvement. They haven't, like I said, this was just done yesterday, so they haven't done anything else yet, but maybe we'll find out.
Okay. So, we had a case here of a person who had, I think, a kidney transplant and then developed histoplasmosis. And it turns out that other people around the country who received organs from this same donor developed disseminated histo. So when you see these fungal infections in the setting of transplant, you have to wonder what might have come from the donor. In this case, it looks really as if it was a lung focus that began the whole thing.
Yeah, and he's from the Central Valley, so he's certainly ripe for cocci. But that's interesting. So did the patient with the transplant, did they have calcified granulomas that were from the prior disease, or do you know? That's really interesting. Okay, and then I'll show this one too, along the same lines. This is a young lady in her 30s, I believe, who came in last month with this radiograph. And you can see that it's kind of interesting. She's certainly got an abnormal mediastinum. It looks like she's got some left paratracheal fullness. You can see, I think this is the aorta here, and maybe a little bit of fullness in the AP window. I think this is probably her reflection of her azygos. But then she's got some subtle nodular consolidation here, and I don't think this is left atrium. I don't have a lateral, but I think this is probably subcarinal lymphadenopathy, and I'll show you. But she's originally from Botswana, immigrated here a few years ago, and has had several months of malaise and not feeling well. And this was the CT that she had done at that time, and you can see that she's just got extensive centrally low attenuation or necrotic lymphadenopathy, including subcarinal. And it goes all the way down into her abdomen. And this was, originally interpreted by elsewhere as suspicious for lymphoproliferative disorder like lymphoma. I guess I don't really like this look for lymphoma, just with the central necrosis. I think it's somewhat unusual. And then what's also important is that it wasn't put together with this, but you can see she's got small foci of central lobular and tree and bud nodules in her right upper lobe, a little maybe bronchial wall thickening there. No cavities, but this, when we reviewed this, we raised the possibility of this all being a disseminated TB. And sure enough, they looked at her, or once they evaluated her, they found out that she had HIV/AIDS. This was a new diagnosis, and this did turn out to be tuberculosis. This was around the time of that CT, just right after it. So MTB from an axillary node FNA that they did.
You can actually see the lymphadenopathy in the axilla. Look at that right axillary and left axillary nodes. Yeah.
Yeah. You're right. There are all these centrally necrotic or centrally low attenuation nodes. And then she just had a follow-up a couple of days ago. She's not doing well. And now you can see in her, she's got more of a miliary pattern as well, which wasn't really apparent on the first study. And I don't know if some of this, they're not sure if some of this is immune reconstitution syndrome. Her TB was pan-sensitive, so it's not a multi-drug resistant TB, but she's not responding yet. I don't know. I generally don't think of lymphoma. I mean, squamous cell metastases, certainly low attenuation, but I think at least in this setting, a fungal or mycobacterial infection's got to be the top thing on the differential, especially with any sort of bronchiolitis, having to put the two together. So those are my cases of infection for this week. Jeff, I want to pull up a couple other cases. I'll pass it to one of you guys for now.
Okay, I'll show a few.
So, Travis, Mycobacterium avium would also be a good consideration for this widespread lymphadenopathy in the setting of HIV. We used to see that all over the place with the low attenuation nodes.
Yeah, that's a good point. You're right, and that was considered too. Yeah, and it was TB that they grew. Yeah, that's a really good point.
Cool. Well, thank you. Those were great. All right, so I wanted to show this case. I can't remember if I've talked about this before or if any of you have ever noticed this, but this was just a nice example of a complete inferior accessory fissure. And what I've noticed, and chime in if you've seen this before as well, but when you have this, the bronchial supply often comes off the middle lobe and not the lower lobe. You'll see you get this accessory bronchus, lateral, medial, and whatever we call this one, inferior. And then this supplies this little segment of lung. And I've seen this several times, and it's always in the setting of a complete fissure, or almost always. And I suspect just because there's no other place for that airway to derive from, because the fissure is complete. So this lobe is really a branch of the middle lobe, and not a branch of the lower lobe. Just an observation, but
yeah, that's interesting. But it's complete, but doesn't it seem a little bit smaller than some of the inferior accessory fissures that we see?
It is smaller, and there is a medial basal segment, right?
Yeah.
So there's an accessory. It's an accessory. It's an accessory lobe off the middle lobe or segment, but it's where you would expect the medial basal segment to be because it usually comes in, or maybe it's just a funny accessory lobe of the middle lobe. I don't know. But yeah, you're right because I guess it usually goes into the inferior pulmonary ligament.
Yeah, that's really interesting.
I don't know, David. Have you seen?
Jeff, you sent a case like this in in 2012.
How do you
You showed a
remember that? But it's I don't know. It's just something. Go
I
ahead.
agree with you that this is small. I just wonder was if you looked at the lower lobe bronchi,
Uh huh.
could you find a medial basal bronchus coming off the lower lobe?
Right here.
Uh,
There's an extra bronchus, so it's an extra segment really of the middle lobe, I guess, because
mhm.
it's isolated from the rest of the lower lobe.
Cool.
All right. Something I've noticed.
Is this a recent case, Jeff, or was this the same case you
Oh, I
sent
saw
years
this
ago?
case a couple weeks ago.
Okay.
All right. This is an interesting case. This was, let's see, I got to change the screen here. So this was a young woman. She's 24. She came in the ED with some chest pain and had this big mass here in the left upper lobe. And so we did an MR. And so these are this is the T2 fat sats, and you can see it's got a lot of signal in it, a lot of heterogeneity. And it looks like it's arising from the lung, separate from the mediastinum. Let's see what else I've got. And I've got some MRA images. So here we're arterial, and you can see there's a little enhancement out in the periphery. And as we go to a later, let's see, that's the first phase. Here's a later phase. We'll see there's progressive enhancement of this tumor, but a lot of central areas, very well circumscribed and seems to be confined to the lung. And then this was just a later phase, and we see this starting to fill in more. So she was scheduled for evaluation of thoracic surgery and then developed some acute symptoms. And so they did this non-con CT, and you can see this mass in the left upper lobe here involving the, I think it was where it was, the upper lobe airway bronchus is above it, but it encases it right here. So she was actually, we did an expedited ultrasound guided biopsy, which showed a spindle cell neoplasm. So she went to the OR and had this resected, and it had actually, by this point, then the cause of her acute symptoms was it had ruptured into the pleura. So the surgeons did an extrapleural lobectomy of this lesion, and it's a synovial sarcoma, which pretty obviously very rare in the chest. But at first we thought maybe this would end up being a neural tumor, but the more we looked at it and with these acute symptoms and really in the lung, and then with the biopsy going for something else there. But interesting that it had ruptured, and it must be growing really, really quickly. So yeah, just an oddity that you don't see every day.
So it was
Go ahead.
lung primary. It wasn't pleura or mediastinum. It was definitely lung primary.
I have the surgeon with me. It was in the lung.
Lung primary.
Lung primary.
But with the rupture, there was a little bit of contained clot and tumor, it seemed, kind of trapped between the apical lung and the pleura with a little bit of free fluid, but primary to the lung.
Interesting.
Yeah, so very, very rare. All right, this was a kind of a...
Yeah. And
Yeah.
quick question.
Yeah.
I mean, is this just the idea that you have potential for like degeneration into any sort of sarcoma within, any organ, just like we see osteosarcomas in the heart occasionally? And
Absolutely.
yeah, that's interesting because usually I think of them arising in the pleura, the couple of synovial cell sarcomas I've seen,
And I've
like
seen
David said.
spinal primaries.
I guess could it have arisen visceral pleura?
Yeah, visceral pleura, potentially.
I guess that could have been the starting point,
Yeah.
but
Yeah.
it was lung. It wasn't like
Yeah.
parietal pleura.
It looks more, on the MR, it's rounder. It looks more like a typical pulmonary lesion rather than a broad pleural lesion. But yeah, I'll see I'll talk to the pathologist and see if they could figure it out because they got the whole thing on block, so they may have figured out where it was from. But it looks like a lung primary. This was a cool trauma case. You can see there's a lot of subacute gas, pneumothorax, a little bit of contusion. But it's kind of cute case is it's a traumatic fistula. This was a rupture not only of the rib, but you got the endothoracic fascia. You've got a rupture of the intercostals, and so you have a pleurocutaneous fistula. But right here at the tip of the lung, you can see a little tiny communication. So I think what happened was there was some alveolar rupture or a little tiny laceration that gave the pneumothorax, which at least contributed to pneumothorax. And so now you've got a communication between the lung. Let me blow it up so you can see a little bit better. But I thought this was really cute. You could kind of get the sense there's a defect. And then clearly you see the defect here. And I know Howard had shown that the case of the cartilage fracture. And this is kind of right at that area. Here's the rib end here. So this is all cartilage. So this was a cartilaginous fracture like Howard showed. But this one communicates between the chest wall and the pleural space. So it took all the muscles and everything else with it. But I thought it was really cute because this little bit of lung going right into that area. I think there's a little communication here. And they were having a little bit of trouble draining that pneumothorax because of the air leak. And then, so just a little thing. Now, this one's kind of cool. This, let me change it here. This was a TAVR workup. And Travis, you have to forgive me. I can't remember how to Cyrix to make 4D images, but I've got the whole data set. But this was picked up incidentally on the CT scan. I'm not sure. I mean, there was an echo actually, but the CT scan showed this big defect here in the interventricular septum, and you can see the hypertrophy. And so one of my colleagues called us about it because we were all just kind of curious about it. And you can see it's extending into the moderator band and all that. So this is just a giant muscular VSD. I'm not sure how it got there. We don't see really any findings of an infarct, just a lot of hypertrophy. So I don't know if it was pre-existing and it's just amplified by the aortic stenosis. He's got a bicuspid valve, or it looks like one there. So I don't know. I mean, Travis, you can shed more light on this. You're a cardiac person.
Is it a complete VSD? Because his RV doesn't look dilated.
No, well, my colleague talked about it as like a dual chamber RV.
Yeah.
Where you sort of it acts like a second chamber. It's not an expression I've heard before.
Yeah, often you see dual chamber RVs in the setting of congenital heart disease where you have some sort of RV outflow obstruction that's below the level of the valve. That's really quite dramatic.
Yeah, I really wish I could watch it dynamically. But what I will do is
go back to the browser and then select the series and then hit the 4D from the browser window.
Like this?
And then
this?
Yeah, I can't see what you're doing, but if you select the full series, hit the 4D, and then when you're in that, then hit 3D.
Okay. And all right, it's loading right now.
Yeah, and then you hit 3D viewer within this sequence.
Okay.
And then you can play from the 3D viewer. Yeah, it's kind of cumbersome, but you may have to pull up the buttons from the toolbar customization.
Oh, let's see. Oh boy.
Well, you can play around with it maybe.
Yeah, I don't know. Oh, let's see. I don't know what button it is. All right. Well, anyway, you can load it up yourself. I'll send the whole data set to you. But it's just kind of cool because I'm trying to figure it. I don't understand this as much, but
Jeff.
Yeah.
Could this just be sort of lumpy hypertrophy of the septum, and we have this cleft between muscle lumps? Is there really?
Well, that's what my thought was, but one of my colleagues is he's a cardiac guy. He knows this stuff, and he looked at the old echo, and he really thinks and the echo showed this to be a defect. But he described it as a sort of a dual chamber RV effect, and it's affecting the moderator band. Because I wondered if it was sort of like that, or sort of a pseudoaneurysm, sort of pooching into the RV.
I mean, this person has a known hypertrophic cardiomyopathy, right? I mean, this is not normal myocardium or chamber dimension, right?
Let's see if I can put it in cardiac axes. Let's see.
Yeah. Charlie Higgins has referred to some of these cases, not this severe, but oftentimes you see multiple clefts in the septum, and he calls it a sawtooth septum. And usually they're incomplete muscular VSDs, but maybe that one is communicating, and somehow the double chamber effect is preventing like a serious shunt. Because you'd think, especially with his LV hypertrophy, that would increase the shunt if he's got any sort of aortic stenosis and increased afterload.
Are you able to see the multiplanars I have loaded?
No,
That's
not right now. I
let me see.
basically just see the toolbar.
Do you see it now?
Yeah, yeah.
So right here is that defect on the short axis. So
Yeah, yeah.
you can play. You guys can play with it and see what you think. But yeah, my colleague, he's pretty good with this stuff. So he went back and looked at the echo and thought
That's
it was
cool.
definitely a VSD. But it's kind of cool. It's kind of weird. I hadn't seen one in a while. So nothing profound this week. More just interesting stuff. All right, David, do you have any cases?
I do. So, is it showing my screen?
Not yet. Oh, not yet.
Not yet.
Can you offer it to me again? Okay, there we go. Okay, this is a case I showed a few weeks ago. I think Travis was away at the time I showed this. Why is it not showing? Let's see.
I see the ghost of a Röntgengram.
Oh, that's right. Okay, so a Röntgen ghost here, and this person has a diagnosis of lymphangiomatosis, and so from the chest radiograph, I'm bringing this case back so some of you may have seen it. There's this lower mediastinal paraspinal mass. There are some rib problems here reflecting lymphangiomas in rib and spine. This person had presented earlier with back pain related to vertebral problems from lymphangioma. So this is the CT scan showing the low attenuation posterior mediastinal mass with what I thought were flea bullets in it. And so in the setting of lymphangiomas, which in this person are multiple, we see them in spleen, they're in vertebral bodies, they're in this retroperitoneal stuff, and then throughout the retroperitoneum of the abdomen here. I thought that these calcifications might be flea bullets because sometimes hemangiomas are associated with lymphangiomas. I went back to check this case to see if there was any documentation of there being a hemangioma component, and there is not. The pathology was outside. It was written about in our medical record, but was not reviewed at the University of Washington. So as far as we know, this is just lymphangiomatosis in this person. And I did find some articles that document dystrophic calcification in the setting of lymphangiomas. So just wanted to make the point that calcifications that look like flea bullets like this don't necessarily mean there's a hemangioma component in this condition. So this is a case of lymphangiomatosis. Jeff, I think you were away when I showed this case before.
Yes, that's the first time I've seen it. That's amazing.
So David or Jeff, can somebody clarify? I always get confused between lymphangiomatosis and lymphangiectasia. And again, it's probably because I've maybe seen one of each or two of each case.
So lymphangiectasia is a congenital dilation of the lymphatic that presents in childhood, and you'll see diffuse septal thickening in those patients, and they can get chylous effusions, but it doesn't cause masses. It actually affects the lymphatics of the lung. I showed it. I have a case, and I'm pretty sure I showed it many years ago. It was a young girl we saw here. I can show it again next week if you'd like.
And David, what did the lungs look like in your case? Because they looked a little busy on that radiograph, and maybe it was just the technique.
I think the lungs were okay.
Okay.
There wasn't a lung problem. And the other thing is, to amplify what Jeff was saying, these are lymphangiomas. These are discrete masses. Lymphangiectasia tends to be more just diffuse, and you've got this involvement of a lot of tissue, but you don't actually have well-defined blobs, as in this case. I hope that squares with Jeff's take on it. Okay. So, because I had titillated people with a hemangioma business, I pulled up this case of a person with multiple hemangiomas. So this mediastinal mass here, definitely abnormal here, is a case of hemangiomatosis. So this person has multiple hemangiomas. It presented many years before with a testicular lesion that was a hemangioma, and here it is in the mediastinum. And this imaging was done, pretty soon after contrast injection. We do see some vessels coming off the chest wall or anterior mediastinum and going into this tumor here. So we can see a vessel supply. Perhaps if we waited longer, we would have seen some opacification eventually within this tissue, which was all composed of thin-walled blood vessels. And there is a lower mediastinal and abdominal component of this. And here we do have some phleboliths in this tissue down here. So phleboliths do fit with hemangiomas, but you can get them in lymphangiomas as well. And here's the rest of the abdominal CT. You've got this stuff going way down. And we come down to the testicle. The left testicle had been resected, and we have these phleboliths. And I don't know whether it's just pampiniform plexus. That's always a possibility. But I think that this might have been, they resected this and they got hemangiomas in the tissue around the testis. So we have pathologic documentation. It looks to me as if there is still potentially some hemangioma down there. Okay, so this is hemangiomatosis. Well, there are hemangioma syndromes, including Maffucci syndrome. This person didn't have the enchondromas to go with that. And this person was lost to follow-up after 2008. And there wasn't any sort of genetic workup. As far as I know, these were the only tumors. It wasn't associated with, you know, Proteus syndrome or something more exotic than that.
Well, it's interesting you mentioned that, David, because I was hoping you were going to show that it was the left testicle, because this is all on the left side of the body, even the mediastinum. I mean, is this some sort of mosaic issue? Because even in the posterior back, you can see it really stops at midline. You see a few superficial hemangiomas up higher in the back. I mean, yeah, there's a little bit to the right, but you know, in the abdomen, it looks like it's all left-sided behind that left kidney, and even in the upper back around the level of the scapula and stuff.
There's a spleen lesion and there's no liver lesion. So, the point, we don't know because he never got a genetic workup. He wasn't visibly deformed, you know, looking at him. He didn't look like a Proteus syndrome.
Yeah.
Stuff like that. It's a very good point.
Yes. Yeah, go back up to the mediastinum in the chest, because it did look like it was involving the right side, but it was kind of more extending from the left. And then the left superficial back right in there, you can see some small hemangiomas
coming off the left.
Yeah, that's really interesting. I've never seen that before. Even the whatever those muscles are, you know, deep to the deep to the lats, and then more superficial along the. That's really interesting.
Very good points. It is surprisingly left-sided here, isn't it?
Huh.
I love this. I love this conference.
Is that a pulmonary embolism on the right, David?
Well, that's the whole thing, huh? Yeah, but it's a right-sided pulmonary embolism, so that doesn't fit. Okay,
Wow.
it's got to. Okay, so then I wanted to show you guys a case that Paul Cameron sent. Paul Cameron was a fellow here a couple of years ago, and he is now in practice in Chicago, and he sees patients from Cook County. So this person came in short of breath and has this peripheral basal consolidation, and had this CT scan, which shows very peripheral ground glass basal predominant, just cleaving to the edges, and was treated with steroids, and a couple days later had cleared up dramatically. So it turns out that the very provocative history was that 12 hours before coming in with this, she had had a friend inject her buttocks with silicone to make things beautiful, I think. And this is silicone embolization. There's a literature about this, and you guys have probably seen this living in weird cities. So here's one article that shows a very similar chest radiograph here and an old CT scan, again with this very peripheral ground glass stuff. And this article also shows peripheral ground glass stuff in several cases. So silicone oil creates a condition, if it embolizes, that's very much like fat embolization. The silicone oil itself is not irritating, it's well tolerated, but macrophages try to take it up,
And was this industrial silicone that they bought at Home Depot or Lowe's? I'm assuming this was some sort of, back alley deal, like the cases that I've seen.
Don't have detailed history about the lot number or the origin of the.
Well, right, because if you Google Black Madam, that was the most famous case of I think I actually showed the images. That it was a woman, an R&B star from London that had flown to Philadelphia and had silicone injection for the same purpose, and at the Hampton Inn near the Philadelphia airport and this lady, Black Madam, got arrested and sentenced to prison because she ended up dying from right heart failure from the silicone embolization. Now, in this case, was there any right heart issue?
I don't think that the CT showed that. Let's go back to see what her right heart was doing.
Yeah, these are always exciting cases.
Well, the artery is big.
I'm amazed how quickly that she improved.
Do you think was there anything in the pathology in those papers about an eosinophilic lung reaction? Because that would, it looks like an eosinophilic pneumonia pattern is something that would melt away that quickly.
Yeah, so I actually showed this case in a conference earlier this week, combined with an eosinophilic pneumonia case, to show that there are other causes of peripheral lung consolidation, such as organizing pneumonia, but also embolic things. So things that are carried in the bloodstream tend to end up against the bases and at the periphery. So I made the point that this distribution reflects the, it's being blood-borne. I agree. I mean, and the reason I paired it with eosinophilic pneumonia is because that's the first thing I would think of, seeing something that's peripheral. So, Travis, I think the PA dilation here is suggestive that there is acute pulmonary hypertension.
Yeah, I've seen a couple cases, and the one that I was referring to from the famous case was actually an ACR case in point within the last couple of years.
Mm-hmm.
And you can see that, but yeah, this is quite impressive.
So thanks to Paul Cameron for sending this case.
All right, I'll have to add that to my differential now. All right.
So the word for having a beautiful rump is calipygia. So calipygia. So this is the radiology of a lure with attempted calipygia.
Calipygiosis.
Oh, right. Now what's the etymology of that one?
So cali means beautiful, as in calligraphy,
Okay.
C-A-L-L-I, and pygia is rump or anus.
Okay. Moving along. Is that it for you, David?
That's enough.
All right, thanks. Travis, you had a few more?
Yeah, I've reloaded a few more. Since David just showed that, I'll revisit this one. This was from Grady, and this was one I was asked to review. This is before I had gotten to Emory. But you can see this is a man, and he was not undergoing buttocks injection. But this was his presentation, and then 3 days later, his radiograph just looks more diffuse and an acute lung injury or diffuse alveolar damage pattern. He's obviously intubated at this time, and he got better over the course of a day, but he kind of just dwindled for over a month in the ICU, and you can see he's trached a month later. This was his CT, and now at this point it's more of just, it looks like some organizing diffuse alveolar damage. Probably he's got some dilated airways in here, some coarse reticulation, but you can see on him that he actually underwent silicone embolization of his pectoralis muscles as part of a gender reassignment. And so his partner had withheld this information until around this time in 2010 about this key piece of history, because surprisingly he went for 2 months before he actually got a CT during this hospitalization, but he died shortly thereafter, and they did an autopsy, and this was all silicone embolization. I think that they did a BAL. Let's see, I can't this has been so long. Yeah, let's see. Yeah, these rare granules, I guess. What are they saying? Rare cells with lipid stain. Yeah. So this was on autopsy eventually. It was another silicone embolization syndrome, but in him it just kind of triggered more of a diffuse alveolar damage and ARDS type pattern. So that was one that I saw before. All right. Now this one I've been holding on to for quite a while, and it's along the lines of some of the other cases I've shown today. But this is one of the craziest cases I've ever been involved with, and this is a guy with head and neck cancer, and you can see back in 2014 he has nothing in his lungs, maybe again a tiny little fissile node, no big deal. So then a year later he comes back and has this CT, and now he has a bunch of cavitary nodules bilaterally. I wasn't involved in this, but they're certainly worried about metastatic disease, and so we were asked to biopsy, and you can see this was my biopsy and where I got involved with this case. And this guy's had, they're pretty high suspicion of metastatic disease, but they want to confirm, so we targeted this lesion. And you'll see that he ended up with a pneumothorax, no surprise, and he's got a little bit of hemorrhage surrounding this lesion, but it wasn't really a complicated biopsy, other than placing a chest tube for his pneumothorax. And he was doing fine, no hemoptysis during the procedure, and this was 2:40 in the afternoon, and at 6:30 at night when I was home, I got a phone call that the patient was in the holding area waiting to be admitted and developed massive large volume hemoptysis and actually died in the holding area in radiology. So it was quite a traumatic case for me, because we went through all sorts of QA and risk management meetings and review of what we did wrong, under the assumption that it was our biopsy that somehow caused his hemoptysis, delayed hemoptysis. And for the record, I can find no cases in the literature of hemoptysis performed or occurring several hours after a biopsy. And of course, at that time he was managed by the nurses, and they didn't put him in the right side down decubitus view or decubitus position, even though that's what you ideally want to do if you think the biopsy is causing hemorrhage, to keep that side down. But to make a long story short, he went to autopsy, and anybody want to guess what they found?
Coxy?
It's a good guess. So he had some kind of low-grade fever and some, just cough off and on, no blood. Well, first of all, what they found, it was actually this lesion that had bled into a bronchial artery. It just happened to occur a couple hours after the procedure. It was this big lesion that's right along the bronchovascular bundle. And these were mets, these were metastases, and this one was super infected with aspergillus. And so I think it was probably, it would fall under the classification of like a chronic necrotizing or a semi-invasive aspergillus. But you can see there's a vessel going right through the middle of this. And yeah, so it taught me a few things. Number one, don't forget about infection, even when you have high clinical suspicion of metastases. Number two, that mets can be super infected. And number three, don't just assume that, you've caused something that's never been reported in the literature. And it was kind of, it was a little, I don't know, I don't want to say gratifying at the end, but at least we were exonerated.
Mm-hmm.
So it was
that was a bronchial artery in the center of this thing, or?
Well, I don't know. It was definitely a bronchial artery that bled into this, and I don't know. I mean, it looks like you can see there's vessels all around the wall of this. I don't know what vessel's right in the middle of this, but even here you can see it's just excavating along the airways and the and the arteries. So I've been waiting to show this one for a while, but it was it was just a traumatic case, but also a really interesting and an instructive one at the same time. So
Travis, was that the only site of aspergillus infection, or were all of these nodules aspergillus?
As far as I remember, it was only that one. I've got the let's see. let's see. So here's the involving a branch of the left bronchial artery. I actually went and reviewed the path or the autopsy with the pathologist, and then most of these were just tumor necrosis, the cavitation. So yeah, when they looked at this, colonization, subsequent infection by Aspergillus.
Wow.
Yeah. So turns out you usually biopsy sick patients and stuff can happen.
Uh-huh.
So on a lighter note, I want to show a couple of consult cases here. This is one I saw last week, and to David's comment just recently about why we like this conference so much, I would not have even thought of this without seeing David's case and a case that Brent showed subsequent to that, and maybe Jeff even showed one of those too. But as you can see, this is a young guy, and I came across him post-transplant. I didn't see this pre-transplant. He's 51 at this time. He smoked a little, but you can see he's got what looks like severe emphysema. But also look at his lower lobes, that he's got severe bronchiectasis. And I suspect, and I don't know this for sure, but this sure looks to me like it's going to be alpha-1 with both bronchiectasis, which I've never seen until David and Brent showed cases of it, and with pan-acinar emphysema. And I've talked to the pulmonologist. He had one alpha-1 level tested a few years ago that was like slightly, or it was borderline normal. It was in the normal range with borderline. But I can't think of a better explanation, because otherwise they weren't sure why he had such severe lung disease at such a young age. And so they're still waiting to get, still waiting for them to get back to me, because I just saw a follow-up post-transplant last week, and that's where I, got this. But have you guys seen a combination of the two? Because I know we've seen cases of lower lobe bronchiectasis that looks identical to this, and then upper lobe, obviously upper lobe, or not upper lobe, but pan-acinar emphysema. So,
Well, Sudhakar made the point a couple of weeks ago, and he said that the mutation is different when alpha-1 is associated with bronchiectasis, and you don't get the emphysema. So that, and I have not followed up on that. I have not read that, but that's what Sudhakar said a couple of weeks ago. So that implies to me that we should not see them combined.
Yeah, I just couldn't think of a better explanation.
Mm-hmm.
I mean, yes, in the upper lobes, it looks, some areas you might argue there's some more paraseptal, but in the lower lobes, it sure looks like just,
How about an immune deficiency in this guy?
Yeah, they evaluated him for it, and nothing that we could find. But I don't know. I'll keep this. I'm keeping an eye on this. I've been pestering the pulmonologist to do some more research, because he gets a lot of his care elsewhere. There was one note that he's being seen by a hepatologist, which again, he doesn't look like he has frank cirrhosis, but I'm still suspicious.
Mm-hmm.
So, but Sudhakar's a pretty smart guy, so I don't know.
I'll give a pull something on that.
So interesting. I don't know, Jeff. Do you have any
The only thing I can think of is, there's that entity of vanishing lung syndrome or giant bullous emphysema, where they're young people who they often smoke, but it's not much, but they develop stuff like in the lungs. But it's probably along that alpha-1 spectrum. There's some enzyme that's that's off that accelerates their tissue destruction.
Usually the cases of giant bullous emphysema we've seen, it's more the bullae just kind of smushing the rest of the lungs down.
Which you kind of see here, but except you have the bronchiectasis. So I'm trying to put it together. And what I've seen with, like what David said, sort of not the genetic side, but the alpha-1, I don't think I've ever seen or heard of the two combined. But I was wondering if he had some sort of something in that spectrum of giant bullous emphysema, where there's something wrong with the protoplasm of his lung that's just predisposed to tissue destruction and elastin breakdown more so. Because, I mean, that distribution of bronchiectasis looks like someone who's got recurrent infections.
Sure, but it looks very similar to the alpha-1 bronchiectasis too. It was very much lower lobe.
Mm-hmm.
So, I don't know. I just thought it was really interesting, and I would have never even thought of combining the two. But
yeah, that's strange.
Maybe I shouldn't. We'll see. All right, I've got one last one. This is just a cute, quick case. This is a older guy, smoker, who came in. This is an old case. I was going through putting together my lung cancer talk for RSNA, but you can see he comes in with a spontaneous pneumothorax, and most of the right lung is collapsed here, and you can see they put in a pigtail catheter. But you'll see the cause. I don't know if this actual one of these two masses is the actual cause. Maybe here you've got a little bit of rupture here, but also more importantly, you can just see that he has diffuse studding of the pleura on this side. And so, and I like to show this to my residents to make the point that it doesn't matter, as long as these are the same pathology of lung cancer, it doesn't matter if one of these is which one is the primary or not, because he has at least, well, he has M1, what will be M1A disease on the 8th TNM with diffuse pleural nodularity. And they actually went in and did thoracoscopic surgery and confirmed that these were all pleural metastases from his lung cancer. So, I mean, obviously we've seen cases of spontaneous pneumothorax just from pleural metastatic disease, usually with sarcomas, but I thought this was a nice one just with the pleural dissemination of lung cancer on that side. So, just a cute little case. Are you guys gearing up for the 8th TNM? Supposed to be released next month, I guess.
Oh boy, so I have to get, just when I've mastered the 7th, I have to learn the new one.
Well, I have to give a talk at RSNA on lung cancer staging, and it's, all of the literature on the proposed 8th says like December of 2016, which is going to be right after my talk, so I'm kind of stuck.
Well, remember the Nelson trial was supposed to be released last spring.
Yeah.
And we're still waiting on Fleischner updates for lung nodules. That was supposed to be 2016 early, so.
Yeah. So, anyway.
All right, well, thanks.
That's the last of my cases for today.
Well, we'll call today, and we'll do next week, and we'll be off for Thanksgiving. We'll be off RSNA week unless everybody's back. I'll be here RSNA,
yeah.
So depending on if people are back, and we'll touch base via email, but otherwise we'll probably jump ahead until December.
And Howard, I know you're watching. I hope you feel better. Sorry you're having issues with your voice. So
All right, guys. Well, thanks.
Talk to you later.
Bye-bye.